Assalamu alaikum everyone and good morning or aapko almost good night. Ramadan Mubarak. Let me introduce today's guest speaker and my dear and close friend Dr. Rashid Sharaf, interventional nephrologist from Texas, USA. He is fellow of American Society of Diagnostics and Interventional Nephrology and board certified in internal medicine and nephrology. So in US, you can't just do nephrology alone. You have to do internal medicine, then nephrology, then come the interventional nephrology. And he's medical director of STAR Vascular Access Center in
आप सही
San
हो सर.
Antonio. So we have worked together for almost 10 years in Texas, and he was our go-to guy for PD catheters. Great guy, great human being, exceptional nephrologist, always willing to help. So we welcome him to share his experience about peritoneal dialysis catheter placement. And I understand he will be talking about fluoroscopic as well as ultrasound guided techniques. And we all know it's our lifeline, the PD catheter for peritoneal dialysis patient. A good catheter like good AV fistula makes your life easier. Otherwise, you can't grow the program we are trying to grow, me and Isab, Dr. Naman, Trif and Byonyks. So we have to have this technique uh, at its excellence so that we don't get any complication. So without further wasting any time, I would request Dr. Rashid Sharaf to please enlighten us with all the experience he has. I think he must have put like more than 1,000 catheters. So we welcome him and please, Dr. Rashid.
Jazakumullah khairan. Thank you very much for the kind introduction. Assalamu alaikum, everyone. Ramzan Mubarak. Hopefully, everybody is fasting, and hopefully, I'll not bore everybody to कि सबको रोजा लगने लगे. So, so without wasting any time, I'm going to get started. Let me start by sharing my screen.
और ठीक है चीज़ां थोड़ियां ਜਿਹੜੀਆਂ ਬਿਹਤਰ ਨੇ ਅਜੇ ਥੋੜਾ ਜਿਹਾ ਸਾਨੂੰ ਲੱਗਦਾ ਕਿ ਪਾਣੀ ਦੀ
So, I'm going to actually talk primarily about percutaneous fluoroscopic PD catheter insertion. But understand this, that ultrasound guided PD catheter insertion is really not that different. In fact, the first stage of fluoroscopic PD catheter insertion is actually the ultrasound guidance. So I'm actually going to spend a lot of time talking about ultrasound. And if you have the ultrasound part, if you understand the ultrasound part, it will make it really easy for you to actually place the catheter, and the chances of getting any kind of complications or any kind of problems with the PD catheter placement, they will be minimized. So, so the objectives are to describe the procedure for fluoroscopic and ultrasound PD catheter placement, discuss the best practices, the expected outcomes, discuss the outcomes comparing laparoscopic and PD catheter, if we laparoscopic and percutaneous PD catheter placement, if we have some time. And of course, what I did not put in over there is ultrasound guided PD catheter placement as well. And of course, we will talk about what the pre-op preparation for these patients should be, or ideally should be like. So the pre-op screening for patients who are going to be getting PD catheter placement. So a good patient is someone who has not had any kind of abdominal surgery, who has a completely virgin belly. But the most important thing when I'm examining a patient is to make sure that the patient does not have any ventral hernias. Now, you can actually do a hernia exam, especially a patient that looks like this, who has had multiple abdominal surgeries. They can have ventral hernias. Inguinal hernias are actually easy. The patient will actually give you a history of having an inguinal hernia. They will tell you that feeling of fullness, heaviness in their groin area, which is which is a telltale, and which will tell you that the patient has some kind of a hernia over there. So it's always a good idea to get that fixed. But the hernias that get you are the ventral hernias. And the simple way to diagnose them is, again, using an ultrasound probe. Just slide that over the abdomen, especially under the scars. Now, keep in mind that the abdominal wall incision might actually be away from where the abdominal scar that you see might be. So make sure you get a nice, complete ultrasound of the abdominal wall. If there are no missing areas where the abdominal wall should be, that patient should actually be a good candidate, whether or not he has had multiple surgeries in the past. The other thing that you want to do is something called um, a slide test. The easiest, that is basically, that slide test is basically keeping the probe on the abdominal wall in different areas and asking the patient to breathe in and out while basically inflating their abdomen or doing abdominal breathing. And that should give you an idea whether there are any intra-abdominal adhesions. Is that a perfect test? No. Is that foolproof? No. But will it give you a very good idea what you're dealing with? Yes. So the idea is that the abdominal wall should be stable and your intra-abdominal structures should slide with breathing. If they are sliding, the chances that they have no or few adhesions is there. If they are adherent to the abdominal wall, then those are the patients that you should be cautious in. Then obviously the patients who are good candidates should be those that are able to follow your instructions. What kind of a start is it going to be? Is it going to be an urgent start? Do you have some time before they will actually start their training? And so on and so forth. And again, different centers, different institutes have different protocols in place for that. Oops.
Excuse me, can I ask everyone to mute their mics, please? Dr. Shahid Mahmood is showing here. He has not, or maybe Dr. Namantri, if you could mute their mics because there is a noise.
So, as far as the workup is concerned, basically the things that you want to know is that everybody is a candidate for PD, except for a few. Like I said, patients who have hernias, there is a relative contraindications in those patients. Patients who have severe malnutrition, that's a relative contraindications. Multiple abdominal adhesions, poor personal hygiene, these are all relative contraindication. But severe inflammatory bowel disease, acute diverticulitis, any kind of an acute infection that's going on, whether it's intra-abdominal or on the abdominal wall, would be a contraindication at that point in time. So these are things that you have to be cognizant of. Otherwise, like I said, pretty much everyone is a candidate for peritoneal dialysis as long as they are able to carry out their own dialysis. Now, the best practice guidelines, these are basically part of the KDOKI guidelines as well, and I'm not going to waste your time talking about that. But when it comes to placement of the PD catheters, infection control is the number one thing. Make sure that everybody in the operating room or in the operating area, even if you're placing it at bedside, that the patient is prepped and draped properly. Everybody is wearing their mask, their sterile gloves, sterile gowns, because it's not just a simple procedure where you're, incising an abscess or draining an abscess or taking out a catheter. You are actually going to place a foreign body in the abdomen. And if you introduce an infection with that, your chances of success or your chances of failure go up significantly. So this is something that simple, basic things that make a lot of difference. Now, when you're planning to put in the PD catheter, the most important thing is to figure out where to put it in or what kind of things that we have to be cautious of. The biggest thing that scares me when I'm putting in these PD catheters is the presence of the inferior epigastric artery. So the inferior epigastric artery is an artery that comes off of the iliac artery, runs upwards, basically at the posterior wall of the posterior rectus sheath. And in my practice myself, I have punctured this artery twice, and I tell you, it's a very scary sight. And if you're doing this at the bedside, that can be even scarier. But there are simple ways to figure this out, where exactly the inferior epigastric artery is. And all you have to do is just move your needle away from where that is. And that's something that I'm going to discuss as well. The second thing is to figure out where exactly do you put the catheter in. If you insert the catheter a little bit too high, the chances that you will get an omental wrap or catheter malfunction are pretty high. If you put it in too deep, the chances that you're going to get drain pain or pain because of the catheter kind of sucking up against the abdominal wall or any kind of a viscous wall are pretty high. The idea is to put it in the Douglas pouch or the anterior rectovesical pouch right here. I don't know if you can see my mouse. So the catheter actually tracks along the anterior abdominal wall until it actually starts to move posteriorly into the mid pelvis area. You do not want it in the deep pelvis, and you definitely do not want it above the pelvic brim. So these are the abdominal wall layers, and this is where good ultrasound skills come in handy. So these are your ultrasound abdominal wall layers that you need to worry about, or you need to identify with ultrasound. And if you have good ultrasound skills, and good ultrasound skills just come with practice, you will notice that the top layer is obviously the skin. So just correlate that with the ultrasound image right here. The top layer is the skin, then comes your subcutaneous or your adipose layer, and then comes the anterior rectus sheath, this thing right here, your anterior rectus sheath. Then comes the body of the muscle, and then comes the posterior rectus sheath, and then the periperitoneal space right here, and then the peritoneum below that. Now, the inferior epigastric artery kind of runs right at this point. So if you were to put color Doppler, when you're getting this ultrasound image, if you were to put color Doppler and the artery is, say, sitting somewhere over here, it will start lighting up. And you know that that's where the artery is. You identify where the artery is. You mark it on the skin, and you stay away from that area. You move a little bit laterally or medially, and you gain that as your access point. So this is just an enlarged view of the same thing. Any questions? Please feel free to ask if you have any questions. I mean, again, this is supposed to be interactive. I would, in fact, prefer that you stop me and ask me questions if you have them right now. Now, this is what my table looks like to begin with. In my case, I use a micropuncture or an 18 gauge needle. And then I have a 0.18-inch wire and a 5 French sheath right here. So these are the three things that are most important. Now, if I am just using ultrasound, then this syringe is filled with just saline. If I'm using fluoroscopy as well, then this has contrast in it. That's the only difference. So once you have your table ready, the best thing to do is to mark exactly what your point of entry is. Now, I typically use a 62 centimeter Argyle catheter, and what that is, I'm sorry, I don't think I have that image, but what that is basically what that means is that the cuff, the deep cuff of the catheter is about 15 centimeter from the coil that's going to be in the pelvic space. So what I do is I measure about 15 centimeter from the symphysis pubis, and I measure about 15 centimeter up. Doesn't matter where the belly button is. The belly button is never a good landmark when it comes to insertion of the PD catheters. The belly button is never a good landmark. Um, so remember that in some people, the belly button rides very high. In some people, especially the obese folks, the belly button can be way down there with the pannus, and you would think that that's the entry point. But the best thing to do is to identify your landmarks uh, on fluoroscopy or using ultrasound. So the idea is identify where your symphysis pubis is and measure about 15 centimeter upwards or cephalad from that. And that would be your entry point.
So one question, Dr. Rashid,
Sure.
from Dr. Yasser, that how can you avoid the inferior epigastric artery? Is there any like point there that you can just highlight?
Yeah,
And second thing
unfortunately,
is,
like I said, I don't have a good image. But if on the color Doppler, so if I were to add color to this ultrasound, color Doppler to this ultrasound, you would actually see the artery light up in the kind of the inferior part or the posterior part near the posterior rectus sheath. You will see the artery light up.
But
So
that's
now.
only with the Doppler. If someone is not using a Doppler, using any
Yes,
other
I'm coming to
technique.
that. If you don't have the Doppler, the artery tends to run somewhere by the meatiest part of the muscle. Okay. So if you were to go laterally or medially, close to the linea alba or close to the transverse abdominis muscle, the chances of hitting the inferior epigastric artery go down exponentially. Okay, so if you cannot identify it or if you don't have a Doppler, the best thing to do is to go, I prefer to go just laterally as close to the transverse abdominis as possible. Now, why do you want to go through the transverse abdominis? Why do you not, or why do you want to go through the muscle itself? Why not just go through the linea alba, which is a completely avascular structure? I'm going to talk about that a little bit further. Ideally, and this is something I had done in the past, that I would go through the linea alba. The problem with that is that the chances of getting leaks are a lot more if you go through the linea, because you're going through a structure that really does not provide you much strength or much support, and the chances of getting leaks are much higher. But again, there's a caveat to that as well. If you're putting in a catheter in a patient and you have the ability or the luxury of waiting 3 to 4 weeks and allowing that cuff to heal in there, then you can go through the midline and should not be a problem. Does that answer the question?
yes, yes, thank you.
So again, then the key is to anesthetize the area well, that you have identified that that's the point of entry that you are gonna be using. Now understand this, your pain receptors are only in the skin and in the peritoneum. So any other structure in between them do not have any pain receptors. So I actually will just give maybe half a cc of lidocaine at the skin and leave it there. And I actually use the pain receptors in the peritoneum as a guide as to when I'm actually entering the peritoneum. So and I tell the patient that tell me if you feel any discomfort. So he will not feel any discomfort when you go through the skin, when you go through the adipose, when you go through the muscle, when you go through the anterior rectus sheath. But as soon as you pop the peritoneum, he will feel that discomfort. So even if I don't have a good visual clue, I will get a good clue from the patient telling me that, yeah, I felt something. And that's when you stop pushing the needle in.
So,
So,
Dr.
and
Rashid, if you
yes,
can just orient ourselves about the lines that you have made. What are these lines and landmarks?
So one of these is the landmark that I have that tells me exactly where I'm gonna be entering from the skin. The second landmark is where I want my deep cuff to be placed. The point that an approximate of where the deep cuff is going to be. And third is the belt line. So, one of the things, especially nowadays in youngsters that really wear tight fitting clothes, um, uh, it's important to know where the belt line is because if you make their exit site at or under their belt line, it's extremely uncomfortable, and these patients are not going to be happy with the job that you do. So typically, my exit sites tend to be a little bit higher and come out from almost at the coastal margin, if you will, in most cases, especially if the patient is obese, then I try to make it at the cephalad portion of the pannus that these patients have. So that's what these lines represent. But these are too many lines, to be honest. The most important thing is your point of entry. The second thing is your belt line. These are the two lines that are extremely important for you to identify and make sure that you remain away from that. That your exit side should either be way below the belt line or way above the belt line so as not to interfere, because that can also lead to infections as well if you're right under the belt line. And then, as far as the pre-op prep is concerned, we will generally give the patient some lactulose or Miralax or some kind of a laxative for a day before they come in. The idea is that the patient should not be constipated. I really do not want fecal material in the colon. It doesn't have to be colonoscopy clean, but at the same time, it should not have hard stools in there. And again, this is just to minimize the risk of bowel puncture. If it's a soft, empty bowel, if you were to hit it with a needle, it will bounce away. If it's got firm stool in it, it's not going to move anywhere and you will go through and through. So the chances of getting complications are more if you have solid stool in the bowel, especially in your. And remember, even though you will say that, hey, my point of entry is way up there, so why am I concerned about bowel rupture or colon rupture or colon? A lot of these patients tend to have very redundant transverse colon. So even though you're going, say, midway in the abdomen, the transverse colon tends to dip down into that area if you were to get a nice ultrasound examination of these patients. Um,
Rashid, what percentage of patient get actually bowel or bladder injury? Like in your experience, have you ever had any patient who have had it?
So, with careful preparation, the chances of getting any of these is absolutely zero. I have done probably about 2,000 plus catheters, and I have not had one case of bowel rupture or one case of bladder rupture or bladder entry. And for bladder, again, if you have an ultrasound probe, the simple thing is I ask the patient to go empty his bladder. We don't even put a Foley catheter in these patients. I ask the patient to go empty the bladder, and then I just do a quick suprapubic scan to see what the bladder looks like. If the bladder is decompressed, I'm not worried about a bladder injury. But bowel injury can be an issue, but with careful prep work, you don't have to worry about that either. However, there is about in the literature, if you read it, there's a 1 to 5% reported incidence of bowel injury in the literature. Um, Now, typically, if the patients are on blood thinners, regardless of what kind of blood thinners, the recommendation is actually to stop them. But I will tell you that in my practice, there are so many patients who have had valve repairs or who are coming immediately from a cardiac catheterization and they just have had a drug-eluting stent placed, and the cardiologist will say, "No way, can you stop the patient's antiplatelet agents?" In those cases, then we just tell the patient that these are the increased risks, uh, but we go ahead and do them. And thank God, so far, unless you actually hit one of the major blood vessels, the chances of getting some kind of a bleeding issue are almost negligible. Uh, uh, and I think as far as the pre-op preparation is concerned, I think this is the most important thing. We will typically give them a dose of Ancef. We don't give them any post-op antibiotics. But then again, this also depends on your institution as to what is the best practice at your institution, what the best thing to do is. Okay, now this is the video that I wanted to show you with ultrasound. Again, just to orient you guys, we are looking at the skin over here. This is the adipose tissue. This is the anterior rectus sheath. This is the muscle itself. And this is the posterior rectus sheath. And we are not looking at the muscle, not transversely, but longitudinally. So my probe is oriented from head to toe. Okay. So this side is the head, this is the feet. Okay. And you can see already that I've introduced the needle from the skin, and the needle is almost at the anterior rectus sheath. And this is where the video is going to start. So uh, if you keep your ultrasound probe well, you will actually be able to see all the movements. And you can see exactly where your needle is going in. Now, the thing that I want to show in this video is the fact that you want to traverse the muscle as much as possible. You want to use the entire length of your needle, which is generally a 7 to 8 millimeter needle, to traverse the length of the muscle. This is called rectus tunneling. The more you travel in the rectus itself, the chances of getting any kind of leaks or the catheter getting pulled out or any kind of problems like that are minimized. Then the other thing that then you will notice that once I get to this point, the posterior rectus sheath, I'll pass through the posterior rectus sheath, and then my needle will slide over the peritoneum before it actually punctures into the peritoneal space. So this is my needle at the peritoneum. And then even though I puncture the posterior rectus sheath here, this is the point where I'm actually puncturing the peritoneum. So I gain another centimeter or two, all of these things to help minimize any kind of leakage, any kind of post-operative problems, and also for a few other things. One, if you are going at this shallow an angle, the chances that you will actually puncture through any of the bowels that might be sitting over there are much less. Two, if your needle is pointing towards the pelvis or towards the feet, then your catheter is also going to follow this track. And then what you're doing is you're telling the catheter that you need to remain in there. You're forcing the catheter to remain in there. By the same token, if you were to go at a right angle, the catheter has free movement that it can go this way or it can go this way. So you want to kind of force the catheter to remain in the pelvis. Am I making sense? And can you see my mouse moving?
Yes.
We
And
could
I
keep
think
moving. Yeah.
this is the most important point that you have made in terms of the entry. I would love to see it again.
Oh, sure. I can play the video again.
The last part of it where you so
So
this last part where it penetrates the posterior rectus sheath, that seems kind of quite difficult, no? The
yeah,
angulation, the
all
angle,
of these
yeah.
are actually pretty firm pushes that you're actually pushing especially in young men who are well built, you actually have to use a fair amount of force to push this in. So, and then you will see that the peritoneum tends. As you push against it, it will tent. So you have to make a definite movement to push into the peritoneum. Did that make sense?
Yeah, I
Yes,
think this
great.
angle makes a lot of sense. I
Yeah.
recently had a catheter and it's migrating all over the abdomen. So, but the if angle is correct like this and the direction, hopefully it would have stayed in the pelvis.
Yeah. So once your needle is in and your 5 French, what I had shown earlier, the 5 French catheter, then all you do is pass an 035 or a larger wire into the abdominal space. So the wire is going in and resting in the pelvic area from here. And at that point, if you have access to fluoroscopy, you can actually inject some contrast. If you get this kind of an image, you know that you're home free. This is great. The contrast is actually spreading outside the peritoneum. I'm sorry, outside the structures along the visceral peritoneum. On the other hand, if you get a line like this, or basically a glob like this, what it basically is that that you're still past the posterior rectus sheath, but still in the periperitoneal space that I had talked about earlier. So you might have to advance the needle a few more millimeters to get into the peritoneal space. Now, this is actually a picture of somebody who went through the bowel uh, into the peritoneum. And this is one of the most feared complications. If you pass the catheter into the bowel, it's easy to know because the catheter is going to be all bunched up and everything. If you're passing your needle through and through, your catheter will look like it's sitting in the right position. It's going to be beautifully oriented and everything. But what it's doing is actually going through and through the abdominal wall. This is something that you have to be super careful of, and that's why it's it's important that you not only get a visual clue, you also get that tactile clue that I was talking about. That you see the needle penetrate into the peritoneum. The patient also kind of alerts you that, yeah, I felt that pain at that time. So all of these, and you don't really advance your needle much past that. If you keep pushing, you might go through and through and not even have an idea that you are in or that you have gone through the bowel. So these are things that you need to watch out for. And again, I don't mean to scare you guys. These are very infrequent complications, but these are things that you have to be. Again, the best complication is the one that you don't have. And the best way to prepare for a complication is not to have one by preparing or thinking of all the eventualities that can happen and avoiding them. So again, this is just a close-up view. This is a normal peritoneogram versus in the periperitoneal space, you get this linear kind of a spread of the contrast as opposed to a cobweb-like appearance.
So, what's the distance between parietal and visceral peritoneum? Like, what's the width like? How far is
It all
your
depends. So between the parietal peritoneum and the visceral, it could be zero. The visceral peritoneum could be sliding against the parietal peritoneum, but in someone who has ascites, you might not even be able to identify the visceral peritoneum. There might be so much ascites over there. So there is no distance. So again, the thing that I talked about earlier, that you don't want constipation, you want it to be you want the bowel to be nice and soft, that if your needle were to touch it, it would move away rather than stand firm in its ground. So this just gives you an idea. It's a cartoon that shows that once your needle goes in, your wire is going to travel interiorly along the posterior abdominal wall, but it's going to be fairly anterior to all the different viscous that is there. So once you have your wire in, all you have to do is uh, I don't think I have that image, but all you have to do is pass your peel away sheath over it and then insert your catheter. And generally, some folks will get a pullback peritoneogram in these cases. I typically don't, because if you know exactly how you have entered, you know exactly where your catheter is going to be. So I'm not really concerned about that. Now, this is exactly where, if you're doing ultrasound guided insertion, this is exactly where you end up. This is whether you're doing a fluoroscopic insertion, this is where you end up. If you're doing a laparoscopic insertion, this is where you end up. Now, one thing that I forgot to tell you in ultrasound is once my needle is in the peritoneum, at this point, generally, I'll have my Doppler window open over here if I'm doing just ultrasound guided, and I will, push in about 5 cc's of saline under pressure, a fast flush of 5 cc's of saline, and that gives a burst of color under the peritoneum or in the abdominal space. And when I see that, I am sure that I'm in the peritoneal space. The other thing is, once I pass my wire, in some cases you can actually see the wire go into the peritoneal space, and you might actually see it travel interiorly. Sometimes you can see it, sometimes you can't. So it's not a very good way of telling whether you're in or not. Now, going back to this picture, I use a micropuncture, which is a sharp needle, but there are all these blunt needles, which especially the Verus needle. I don't know if you guys, if you have heard of the Verus needle. This is a needle that actually has a blunt tip, but when you start pushing against a firm object, a sharp point of the needle comes through, and as soon as it enters the peritoneum right here, because it's, you have pushed through the firm areas and you have gone into an area with no pressure, the sharp end of the needle falls into the blunt stylus, if you will. So you don't really, the chances of puncturing any of these organs is minimized with the Verus needle. So this is something, if you're not sure, if you don't have any ultrasound or fluoroscopy, you could actually just go through the Verus needle, and that has a very good tactile feedback that you would get from the Verus needle, and the chances of puncturing any of these organs are almost nil.
Is
Rashid, was that the
Dr.
technique Dr. Hamner used to use because he used to put in his own catheter, Dr. Hamner, remember?
So the technique that he used to use was something called peritoneoscopic uh, placement, where what they would do is a small rigid
Trocar.
peritoneoscope that they would place in there. Then they would insufflate the abdomen with CO2 just to separate and take a good look, make sure that you were in the right space before putting in the catheter. The problem with that is that you do require anesthesia, because putting CO2 in the abdomen is it's not a very comfortable sensation. So these patients require anesthesia, and you really cannot do it at bedside, or you really cannot, um, and you require that specialized equipment as well, the peritoneoscope.
Rashid, the Brigadier Nadeem in CMH Islamabad, he's modifying the Veris needle so that it can be used, only for the peritoneal dialysis catheter placement.
Okay, yeah, yeah. The Veris needle is actually a very good tool for if you don't have any other things like I said, the fluoroscopy or ultrasound. If you don't have that, then the Veris needle is something that I use. But again, over here, that's usually a non-issue. The Veris needle tends to be a little bit more expensive than the micropuncture that I use, so I just tend to go with the micropuncture. But yeah, it's a great needle. Um, yeah, now this is another thing that some people will actually, you were asking me what that second line was. Some people will place a line over here, then they will make a large enough incision to get down to the anterior rectus sheath and place a stitch around it. And you can see that it requires a pretty large incision. I tend not to do that. And especially if you're trying to do a minimally invasive surgery, it's it's probably not required. Um, and there is actually data to support the placement of a suture in some cases, um, either to prevent the extraction of the catheter or to prevent leakage. But I have actually got data that hopefully I'm going to publish soon in almost 500 patients that I have had, that we have had less than 1% fluid pericatheter leak with the method that I use. So, so compared to this is my incision. So you can see that there's no way for me to get in there and put a stitch in there. But what I do is I will dissect down and make sure that my deep cuff is as close to the rectus sheath is sitting right over here and not in the muscle. That's what I try to do to make sure that my deep cuff is sitting over there. There's no way for me to push the cuff into the muscle itself.
So one question, without suture or stitch, do you need to give more time for catheter immobilization? Like you have to, no?
So most of our catheters, and this is what we looked at as well, that most of our catheters, we started using them within 48 hours of placement, and that by definition is urgent start. Most of the catheters were urgent start, and like I said, less than 1% leak, less than 1% chance of extrusion of the cuff. So, and then comes the tunneling. Now, tunneling and the exit site. So, the exit site, what I typically tend to do, I typically make the exit site a little bit longer or the tunnel a little bit longer for multiple reasons. One, it definitely gives you some kind of a buffer for infection. It also, if this cuff were to get extruded, or if this catheter gets caught up in the shalvar as they are trying to pull it up or down, the chances that the catheter would get extruded would be extremely minimal if the exit the tunnel is long. So what I do is I make the tunnel super long, and you can see that my exit site is higher than my entry point. The key is to make sure that your exit site is pointing down or laterally. You never want your exit site pointing up, even though my exit site is higher, but you don't want it pointing up. So what I do is, in order for this to happen, I basically make a stab incision at this point, at this place, and point it towards the contralateral shoulder. So that way, the catheter is kind of hanging down in the left lateral position, so it doesn't really point up. The point behind that is that you do not want any of the dead skin, or as they bathe, as they shower, you do not want all the water and stuff to get into the tunnel. So That's why you want the exit site pointing away or down rather than up. The other thing is the exit site, it should just be a simple stab incision, or depending on the kind of tunneler that you have, there are tunnelers that will actually make just a perfect cut from the inside, that will just make it nice and snug. You never want your exit site to be bigger than the diameter of the catheter itself. And as a rule, I never place stitches around the catheter. That you're only asking for disaster. These are silicon catheters, as opposed to the polyurethane permacats. These are silicon catheters. They tend to be very flimsy. So if you're not careful, you will cut through them very easily. So never ever put any kind of sutures around these catheters. Even if you have to put a suture next to it, you can do it, but don't ever, circle the catheter with your suture. And at the end, this is what the belly looks like. A subdermal suture over here and nothing over here. And the PD catheter positioning, ideally, like I said, I like for it to be in the mid pelvis, not too deep, not too high, and that I have found to be the sweet spot. Minimizes the chances of catheter migration because of omentum, minimizes the chances of any kind of other complications like drain pain. Once we have done that, we actually flush the catheter with about 250 to 500 of saline just to flush it out, make sure the catheter is working well, both under suction and under gravity, to make sure that if the patient is going to be on a cycler, that the cycler works well. If the patient is just going to be on CAPD, that the CAPD works well as well.
Dr. Rashid, you've made a very long tunnel. So how
Yes.
far the exit site is from the external cuff?
So this is my entry point. So my deep cuff is somewhere over here. My superficial cuff is somewhere over here. So I've got all this extra length for the for the external tunnel. You don't have to. I mean, I could have brought the catheter out over here. So ideally, the teaching is that it should be about 2 centimeters to 3 centimeters away from the exit site. In my practice, what I've noticed is it's so much safer to make it a little bit longer. Yeah.
So I'm just worried whether it is going to lead to like two tunnels. So you may, if there is some infection, there's a tunnel between the two cuffs, and then there is a long tunnel from the exit side to the external cuff.
No, I don't understand. What do you mean by two tunnels? I'm sorry.
Because there's a long space from
Mm-hmm.
the external cuff till the exit side. So it's
Right.
kind of a, like subcutaneous tunnel there also.
Yeah, honestly, I have not found that to be a problem. I have not found that to be a problem. As long as you take the patients take care of the exit site, I have had patients who do get cuff infections. And if they do get a cuff infection, that usually means that I'm going to take out the catheter. But I have had them get cuff infections, especially when they are closer to it. These longer tunnels, I have honestly yet to have any kind of a cuff infection when the tunnels are longer. So for me, these have actually been a better safety net.
Okay.
So
Uh,
for
and
obese
that's why,
patients, like, sorry.
go ahead. I'm sorry.
So for the obese patients, the patients who are morbidly obese, that the tunneling and the exit site, how would it differ?
So for the obese patients, the tunneling and the exit site would probably have been over here. I would have pointed
So
my
that they could see.
exit site up there. Yeah. Because if this was the pannus of the abdomen and this was the most the convex part of the abdomen, I would be above the convex part, if I'm making any sense.
Yes, yes. And one more question, just by the way. So, for obese patient and patient who have multiple surgeries, so do you do this routinely or do you refer them for a laparoscopic procedure?
So again, even patients who have had multiple surgeries, the thing that I had said earlier, that you can just scan their abdomen with an ultrasound, do the slide test, make sure that their abdominal wall is intact and they don't have any ventral hernias. There's no harm in attempting a placement of a PD catheter. Not all patients require laparoscopic placement. You can definitely have this. The surprising thing is I've had patients with completely virgin abdomens who have multiple adhesions inside, and I've had patients with multiple surgeries who have no adhesions. So it's if you don't check, you will never find out.
So one relevant question about the cost, like cost might be different in Pakistan, but in US, laparoscopic must be more expensive as compared to the percutaneous technique. Is that right? Because hospitalization, general anesthesia, theater, and all that.
100%, 100%. The when I do it, and again, I work out of an ambulatory or an outpatient surgical center, so my costs are minimal. So to put in a catheter like this costs me probably about $250. Now, the same procedure in the hospital setting would be close to $3,000, the cost. So there's a major difference over there as far as the cost is concerned. So the complications, am I going over time? Just warn me, please, Dr.
No,
Tarif.
that's good. That's good. One
Yeah.
quick question. Is there any difference you mentioned about cycler versus CAPD? Is there behavioral difference?
There is definitely a behavioral difference because when it comes to the cycler, there's an active pull on the catheter. The cycler is actively pulling the fluid out versus CAPD, where you're letting gravity do all the work.
So what difference, what should we learn one
So
versus the other?
So what ends up happening is if you don't have your catheter in the right space or the right place, your chances of getting um, uh, drain pain are much higher with CCPD as opposed to CAPD.
And if patient is not able to drain well on a cycler, but his patient is able to drain well on CAPD, does that mean that catheter
It's
is
getting
correct?
it's getting sucked up against the wall. The catheter is getting sucked up against some kind of a wall or some kind of a bowel or bladder or something.
And then
Even
that
if they're not experiencing drain pain, if they are having drain difficulty with a cycler and not with ambulatory gravity assisted drain, then it's definitely got to be some kind of a one-way valve that they have a problem with.
then what do you suggest in that situation?
Reposition the catheter.
So I
So
think
there are many ways of repositioning.
so I think the first
That's a topic for another time.
So, Rashid, as you mentioned, the most important thing is when you put in the catheter, at that time you do a suction with the syringe to see whether it is, is there a pull there or not.
Yes,
And if there is nothing, it's a free flow, then it means that it's not snug to any organs or, bladder or bowel. That could
absolutely.
be the initial. So
Absolutely.
since we have a
So
cycle here, so we need to make sure that we just don't look at the gravity drain. We need to do a syringe suction also, just to make sure that there it is fine.
absolutely. So I actually use a 60 cc syringe. That way I can really put a pretty hard suction on it. And that 60 cc syringe should fill up within 4 to 5 seconds. So if it's not filling up well, or if the patient complains of pain when I start filling up my 60 cc syringe, then I know that I have to reposition the catheter. And while the patient is still open, it's much easier for me to reposition it before I actually tunnel the catheter, because I only have one fulcrum that I'm dealing with. Once I tunnel it out, now I have two fulcrums that I have to work around, and it becomes almost impossible to work around two fulcrums.
So most important thing is that before you make the tunnel, just make sure that the catheter
The catheter
is
is
in the right
working well.
place with the gravity flow and the syringe 60 cc suction there.
Yes. And then the final thing is, obviously, when you tunnel, you should check the viability of the tunnel itself, that you haven't left a kink. It's also very important that that also could act as a one-way valve as well sometimes, that it will let the fluid go in, but the kink might actually prevent it from draining out.
Now, what would while making the tunnel, what could be the possible reason of the catheter getting twisted or like turned from one side to the other, misplaced?
So yeah, if you don't uh, really pull on the catheter, so what I do is when I'm tunneling out, I'll usually use a set of forceps to grab my deep cuff here, deep cuff right over here, and then pull on my catheter as hard as I can while holding my catheter down in this place. What that ensures is that this catheter that's in the tunnel is nice and straight. If I don't do that, it could potentially leave a kink. And that becomes especially important thing to do, especially if the patient is an obese patient, which most of my patients are over here. It becomes extremely important because you might not see that kink initially, but when the patient sits up, that catheter might kink on you. So it's important that the catheter should be nice and straight through the tunnel.
And what about that white line on the catheter? Does it help you in orientation?
It helps. We honestly, I used to pay it a lot of attention as far as the orientation is concerned. Ideally, this should be either facing the sky or the floor. In this case, this is facing the ceiling. What that does, it makes sure that your catheter is in this position rather than in this kind of a position. So you want the catheter to be in this position rather than this position. So that's what the white line helps with. Any questions?
Please go ahead.
Yeah. So now, as far as complications are concerned, if you encounter some kind of a bowel perforation, if you're just going with a micropuncture needle, honestly, I don't even stop for the bowel perforation. If I notice that I've punctured the bowel, I'll pull my needle back and just slightly angle it differently and see if I can get in. I'll give them an added coverage with some antibiotics, but I don't stop my procedure. If, however, you dilate and you make that hole any bigger than the micropuncture needle, then you really have to get a surgical consult. They might have to oversew it or do a partial colectomy or whatever the case might be. Bladder perforation, I think it's criminal to ever have a bladder perforation, because these are some things that should never happen. This is something that should easily be avoided. All you have to do is just put an ultrasound probe over the suprapubic area and make sure that your bladder does not extend outside the pelvis. But make sure you get the patient to empty the bladder, or you can place a Foley catheter before the procedure. Bleeding, we talked about this already. Ultrasound guidance, I think this is the key to preventing any kind of bleeding complication, but you can use whatever tools you have. Like I said, it's good to stop the anticoagulants. Um, uh, But if you cannot, then you cannot. So I've done PD catheters in patients with all kinds of anticoagulants, and I've done well. But patients that I've had
So
problems with,
someone
uh-huh.
has asked like if you could stop the anticoagulation like Loperin and Plavix, how many days before the procedure? Like for
So if
surgical
you
procedure, it
could,
might be different.
yeah, if you could, then Plavix should be stopped at least 7 days. Plavix and aspirin. Um, at least 5 days is what I go for. Uh, but if, like I said, if you cannot, then you cannot. Uh, Honestly, if you do it properly, there should be no more than 2 to 3 cc's of blood loss. Now, another thing that to watch out for when it comes to bleeding is patients who have liver failure, who have cirrhosis. They might have some caput medusae over there. They might have some varicosities along the umbilicus. So stay away from the belly button, especially in those patients. So, and like I said, the belly button is never a good landmark for you. But in those cases, I would definitely use the lateral edge of the rectus muscle and stay away from the belly button in those patients. So the goal is to have at least a 1 year catheter survival of greater than 80%. You don't want less than 20% of your, or you don't want more than 20% of your catheters to fail. At any point in time, your peritonitis rate should not exceed one episode every 18 months. Fewer than 10% of the catheters should be removed for infectious complications. Bowel punctures should be less than 1%. These are some of the goals that we have in our practice. Some of the recommendations from KDOKI. So exit site infections should be less than 5% within 2 weeks. Peritonitis rates should be less than 5% within 2 weeks of catheter insertion. Honestly, in our practice, with the way we do things with in the minimally invasive fashion, making sure that infectious precautions are taken, our numbers are way below that. Now, when it comes to catheter malfunction, we have about a 5% rate of catheter malfunction where the catheters that we place 2 weeks later, they are back because of either having drain issues or having drain pain or something like that. And I think some of these issues that we discussed, that the catheter might migrate. It's very easy if your catheter is not in the right place for the omentum to grab hold of that catheter. So the sweet spot, like I said, is kind of the mid pelvis area, but again, it's not foolproof, and that's what I'd said in the
So,
beginning as well. It's not foolproof. We still get about 5% malfunction.
related to catheter-related infection, we had seen like at least for the catheter placed here a significantly increased risk of peritonitis, especially within 2 to 4 weeks. So we are not doing percutaneous as far as I know. It's either laparoscopic or mini laparotomy. So what could we do? Obviously, in addition to following all the universal precautions and aseptic technique, I'm unable to understand like what could be the factors. Is it if it happens within 1 to 2 weeks, is it like the procedure related? Or it could still be during the irrigation and flushing period, or maybe we are using it too soon. So I just want to dig down into it, like what could be the factors, because it's very difficult and it's very annoying that we are having significantly high risk of peritonitis.
Yeah. And when they happen within 2 weeks, the surgeon will blame the dialysis staff, and the dialysis staff will blame the
Yeah.
surgeons.
And
So
nephrologists
it's
would blame the both of them.
so it's difficult to say who is to take the blame, but honestly, it's difficult. I would still, if it happens within 2 weeks, I, as an interventionalist, I, as a surgeon who's doing it, I have to take responsibility. I have to take responsibility
And this
for.
is despite the fact that you mentioned you give like one dose of cefazolin or augmentin or something, that these patients have been on antibiotics starting from the day of surgery for subsequent 2 weeks, like big guns like meropenem and Nazgul and linezolid, things like that.
Oh,
So
wow. Okay.
and then we have a significantly high risk of different organism and bugs growing which are multi-drug resistant, like many of the organism are just sensitive to cholesterol only, like what to talk about
My goodness.
piperacillin and meropenem. So that makes it, so that's why I'm very much interested that it seems to me that with the percutaneous technique, since there is no operation theater involved, there are not that many cuts involved, maybe the risk of infection would or should go down if we use it correctly, because we don't
Uh,
see when they put in the catheter or when they do fistulogram that patients are coming back with infection and all that. So that should be true with the procedure if it's done percutaneously.
Yeah. And I totally agree with you. There's something got to be in the OR or with the sterile technique that they're using. There's got to be somewhere where the chain breaks
Because
as
you
far
just
as the
can't
sterile
blame it
technique
on
is
the
concerned.
patient, is that right? Because patients, like even if it's the patient factor, still their training has to be our responsibility, like, whatever they are doing with the catheter. So that's very concerning. And me and Dr. Naman Tarif and others are looking into it. What can we do to decrease the risk of peritonitis?
Yeah.
I think
No,
this is
honestly, I
this
would
is
have
one
a
of
sit down. I'm sorry,
this
Dr.
is one
Tarek.
of the presentation. This is one of the presentation that is directed toward that end.
Yeah. Honestly, I would have a sit down with the surgeons and ask them to review their sterile technique. So when I'm placing a permacath, when I'm doing I do all kinds of vascular procedures in my center. So if I'm doing thrombectomies or fistulograms or stent placement, those kind of things, I'm honestly not that worried. But when I'm placing in tunneled hemodialysis catheters or especially PD catheters, I a sign goes on the door that nobody's allowed to enter the OR until the procedure is complete. So you wanna reduce the traffic in the OR. You don't want any unnecessary people standing by or who may or may not be completely conscious or cautious about the sterile technique. So uh, these are little things that probably go a long way in preventing these kind of infectious complications. And that's the number one reason for a PD catheter loss, infections.
So we have Dr. Mohammad Anis also here, who is part of one of the big program with almost 35 patients on PD and CAPD and APD. Dr. Anis, do you have any comments here?
Thank you, Dr. Rahman. Uh, First of all, I'm thankful to Dr. Rahman for organizing such an elaborative talk, and especially thankful to Dr. Sharif Sharaf, Rashid Sharaf, making such an difficult procedure is very simple and elaborative way. And I wish if he can come sometime in Pakistan, he can have hand-on training for this sensation of this catheter. And again, thank you very much for organizing this activity.
Yeah, no, I would love to do that. In fact, we have had one such workshop in the past with Dr. Chima.
Angina.
Yeah, inshallah, we can do that again.
But that was done under fluoroscopy. This time we will just do it ultrasound guided.
Ultrasound guidance, yeah.
Yeah. Okay.
So yeah, and these are some of the advantages of doing it. And again, I think we touched upon all of these things. The disadvantages sometimes, people who have hernia repairs, those patients that require degeneralisis or other procedures are sometimes best served with laparoscopic placement. But if you look at the meta-analysis, what is best, whether it should be laparoscopy. If you speak to a surgeon, he will say that, oh, laparoscopy is the best thing. If you speak to a person like me who cannot do laparoscopy, I'll say that percutaneous is the best. But the fact of the matter is that 90% of the patients that we serve can probably get by with either one of them. Um, but there is a definite role for laparoscopic procedures, especially in patients who have had multiple surgeries, who we expect who may have adhesions and would be best served that way.
And the meta-analysis didn't show any difference, is that right, between all the
No, the
techniques?
meta-analysis did not show any differences that the incidence of leak, the incidence of infections, the incidence of all kinds of
Catheter malfunction.
malfunction, they basically came out the same.
So, quick question, going back to your outcome goals, I was very shockingly surprised to see that we are expecting 2 failures out of 10 within the first year and fewer than 20% catheter removed. That means we should or we realistically expect 2 failure out of 10, right?
Yes, that is the KDOKI guideline. But again, those are the general goals. Those are the general standards that have been set by KDOKI and by the various whether it's the American Surgery Association or ASDIN. But if you come to my center, my goal is that every catheter, 95% of the catheters should work. 95% of the catheters should be infection free. Our infection rates are zero. So far in the past 3 years, we have not had any case of infection. Like I said, 5% of my catheters do come back with some kind of malfunction, and most of those require either some manipulation of the catheter, either by with the use of a wire or some other simple technique to get it going. Oh yeah, one thing that I forgot to mention is that if you encounter intra-abdominal bleed while you're putting this in, and it's not unusual to have some kind of an intra-abdominal bleed, you can easily nick with when you're going with the needle, you can easily injure one of the peritoneal vessels or even the omental vessels. If that's the case, it's a good idea to pack it with some heparin. How much heparin? It's up to you. I will usually pack with about 2 to 4,000 units of heparin in the peritoneal space, because what you don't want is your catheter clogging up. That heparin that you use will not be an anticoagulant, systemic anticoagulant. All it will do is prevent local clotting of blood. That when you go to flush the catheter, you find that it will flush easily and not be clotted.
When you're talking about infection, it is related to the catheter placement procedure.
Yes, yes. And that's why exit site infections or peritonitis or any of these things within the first 2 weeks, like I said, if it's an infection that happens within 2 weeks of me placing the catheter, I have to accept the blame, regardless of who it is.
So one more question related to laparoscopic versus this. So laparoscopically or with the mini laparotomy, when they put in a catheter, so there is a bigger incision and all that. So the immobilization of the catheter, should it be like, I remember we were told not to, change the dressing unless it's soaked or something, to leave it like that for a week to 2 weeks, let it heal. And then, you could start irrigating maybe after 72 hours and then once a week. Uh, if it's not for urgent start and it's laparoscopically or with the mini laparotomy, is it a good idea to wait for 1 to 2 weeks before you actually start using the catheter and leave it immobilized?
Honestly, I encourage the use of the catheter within the first 48 hours. I can totally understand when it's done, especially with a laparotomy, where the incision is much bigger, because then the chances you're increasing your chances of developing a ventral hernia. So you definitely do not want to use large volumes for 3, 4, 5 weeks even. But with laparoscopy, I see no reason why you should not be able to use it within the first 2 weeks.
Okay.
Yeah.
Thank you.
So one
But
thing
again, unfortunately, one of the things that happens, and most surgeons forget to do this, is that if they, and typically with a laparoscopy or laparotomy, there's usually a significant amount of blood in the peritoneal space that they may wash some of it out, but they still leave quite a bit behind. And it's a good idea to heparinize that before they and this is something you can have a discussion with your surgeon, that please leave some heparin in the peritoneal space before you pull your trocars out.
going
I'm
back to
sorry, somebody had a question that I forgot.
No, I'm saying going back to these goals. I love these goals. We had taken a screenshot of this. The number three, I'm sure we are right there with great program under Dr. Anis' leadership. We are at 0.65 per patient risk, which is very encouraging because he's
That is,
serving.
yeah, these are ideal numbers. These are, yeah, these are good numbers. These are the ones that have been recommended by different societies and KDOKI.
And he is serving a lot of underprivileged population, which is very compromised hygiene level. And one, two, and remaining four, five, six, seven. Actually, we can take it this as academic exercise and plot our data. We have all the data. We can go back and get back to you and show where we are above or below.
Right.
So
If there are
we
no
are, I
more,
think, 15 minutes over time.
Yeah.
yeah, so if there are no more questions, we thank you very much, Dr. Rashid Sharaf, and Farooq and Noman and Dr. Anis for organizing all of this and giving me the opportunity to also ask some questions. So that was great presentation. I think we should continue that, and that would keep us sensitized and keep us comparing our data with the international and your data so that we remain on our toes and do the best for our patients. So thank you very much.
Thank you for this opportunity, Farooq. Really, I appreciate you coordinating this, and Dr. Tarif, as always, I hold you in the highest regard. And
Thank you.
Dr. Chima, you're my buddy, so so we are good on that. So no, Jazakumullah khairan once again. Thank you so
Thank
much.
you.
Thank you,
Thank you very
everyone.
much. Thank you very much. Thank you for the great session.
Assalamu alaikum.